Chapter 1: Attachment, Loss, and the Experience of Grief. Attachment Theory. Before one can fully comprehend the impact of a loss and the human behavior associated with it, one must have some understanding of the meaning of attachment. There is considerable writing in the psychological and psychiatric literature as to the nature of attachments, what they are, and how they develop. One of the key figures and primary thinkers in this area is the late British psychiatrist John Bowlby. He devoted much of his professional career to the area of attachment and loss and wrote several substantial volumes as well as a number of articles on the subject. Bowlby's attachment theory provides a way for us to conceptualize the tendency in human beings to create strong affectional bonds with others and a way to understand the strong emotional reaction that occurs when those bonds are threatened or broken. To develop his theories, Bowlby casts his net wide and includes data from ethology, control theory, cognitive psychology, neurophysiology, and developmental biology. He takes exception to those who believe that attachment bonds between individuals develop only in order to have certain biological drives met, such as a drive for food or the drive for sex. Citing Lorenz's work with animals and Harlow's work with young monkeys, Bowlby in 1977, points to the fact that attachment occurs in the absence of the reinforcement of these biogenic needs. Bowlby's thesis is that these attachments come from a need for security and safety. They develop early in life, are usually directed toward a few specific individuals, and tend to endure throughout a large part of the life cycle. Forming attachments with significant others is considered normal behavior not only for the child, but for the adult as well. Bowlby argues that attachment behavior has survival value, citing the occurrences of this behavior in the young of almost all species of mammals. But he sees attachment behavior as distinct from feeding and sexual behavior. Attachment behavior is best illustrated by the young animal and the young child who, as they grow, leave the primary attachment figure for increasingly long periods of time to search an ever-widening radius of their environment. But they always return to the attachment figure for support and safety. When the attachment figure disappears or is threatened, the response is one of intense anxiety and strong emotional protest. Bowlby suggests that the child's parents provide the secure base of operation from which to explore. This relationship determines the child's capacity to make affectional bonds later in life. This is similar to Erik Erikson's concept of basic trust. Through good parenting, the individual sees himself as both able to help himself and worthy of being helped should difficulties arise. Obvious pathological aberrations can develop in this pattern. Inadequate parenting can lead people either to form anxious attachments or to form very tenuous attachments, if any at all. Various attachment styles can be found in Chapter 3. If the goal of attachment behavior is to maintain an affectional bond, situations that endanger this bond give rise to certain very specific reactions. The greater the potential for loss, the more intense and the more varied these reactions are. Quote, in such circumstances, all the most powerful forms of attachment behavior become activated: clinging, crying, and perhaps angry coercion. When these actions are successful, the bond is restored, the activities cease, and the states of stress and distress are alleviated, end quote. If the danger is not removed, withdrawal, apathy, and despair then ensue. Animals demonstrate this behavior as well as humans. In The Expression of Emotions in Man and Animals, written during the latter part of the 19th century, Charles Darwin described the ways in which sorrow is expressed by animals as well as by children and adult human beings. Ethologist Conrad Lorenz has described this grief-like behavior in the separation of a gray-legged goose from its mate. This is Lorenz in 1963, quoted by Parks in 2001. The first response to the disappearance of the partner consists in the anxious attempt to find him again. The goose moves about restlessly by day and night, flying great distances and visiting places where the partner might be found, uttering all the time the penetrating trisyllable long-distance call. The searching expeditions are extended farther and farther, and quite often the searcher itself gets lost or succumbs to an accident. All the objective, observable characteristics of the goose's behavior on losing its mate are roughly identical with human grief. There are many other examples of grieving in the animal world. Several years ago, there was an interesting account about a dolphin in the Montreal Zoo. After one of the dolphins died, its mate refused to eat, and the zookeepers had the difficult, if not impossible, task of keeping the surviving dolphin alive. By not eating, the dolphin was exhibiting manifestations of grief and depression akin to human lost behavior. Psychiatrist George Engel, speaking at the psychiatric grand rounds at Massachusetts General Hospital, described a case of bereavement in great detail. This case sounded typical of the kinds of reactions that you would find in a person who has lost a mate. Later in his lecture, after reading a lengthy newspaper account of this loss, Engel revealed that he was describing the behavior of an ostrich that had lost her mate. Because of the many examples in the animal world, Bowlby concludes that there are good biological reasons for every separation to be responded to in an automatic, instinctive way with aggressive behavior. He also suggests that irretrievable loss is not taken into account, and that in the course of evolution, instinctual equipment developed around the fact that losses are retrievable and the behavioral responses that make up part of the grieving process are geared toward reestablishing a relationship with the lost object. This biological theory of grief has been influential in the thinking of many, including that of British psychiatrist Colin Murray Parkes. Other prominent attachment theorists include Mary Ainsworth and Mary Main. The mourning responses of animals show what primitive biological processes are at work in humans. However, there are features of grieving specific only to human beings, and these normal grief reactions are described in this chapter. There is evidence that all humans grieve a loss to one degree or another. Anthropologists who have studied other societies, their cultures, and their reactions to the loss of loved ones report that whatever this society studied, in whatever part of the world, there is an almost universal attempt to regain the lost loved object, and or there is the belief in an afterlife where one can rejoin the loved one. In pre-literate societies, however, bereavement pathology seems to be less common than it is in more civilized societies. Is grief a disease? George Engel in 1961 raised this interesting question in a thought-provoking essay published in Psychosomatic Medicine. Engel's thesis is that the loss of a loved one is psychologically traumatic to the same extent that being severely wounded or burned is physiologically traumatic. He argues that grief represents a departure from the state of health and well-being, and just as healing is necessary in the physiological realm in order to bring the body back into homeostatic balance, a period of time is likewise needed to return the mourner to a similar state of psychological equilibrium. Therefore, Engel sees the process of mourning as similar to the process of healing. As with healing, full function or nearly full function can be restored, but there are also incidents of impaired function and inadequate healing. Just as the terms healthy and pathological apply to the various courses in the physiological healing process, Engel argues that these same terms may be applied to the courses taken by the mourning process. He sees mourning as a course that takes time until restoration of function can take place. How much functional impairment occurs is a matter of degree. Rather than using terms like restoration and recovery, I prefer to use the term adaptation. Some people make a better adaptation to the loss, while others make a less good adaptation. In Chapter 5, we'll look at complicated mourning, where individuals are not making an adequate adaptation to the loss. Before we look at the characteristics of normal grief, it would be useful to look at three terms that are often used interchangeably: grief, mourning, and bereavement. For purposes of common understanding, in this book I am using the term grief to indicate the experience of one who has lost a loved one to death. Grief is a term that can be applied to other losses, but this book primarily addresses losses due to death. Mourning is the term applied to the process that one goes through in adapting to the death of the person. Bereavement defines the loss to which the person is trying to adapt. Normal grief. Normal grief, also referred to as uncomplicated grief, encompasses a broad range of feelings and behaviors that are common after a loss. One of the earliest attempts to look at normal grief reactions in any systematic way was done by Eric Lindemann in 1944 when he was chief of psychiatry at Massachusetts General Hospital. In the Boston area, there are 2 Catholic colleges well known for their football rivalry. Back in the fall of 1942, they met for one of their traditional Saturday encounters. Holy Cross beat Boston College, and after the game, many people went to Coconut Grove, a local nightclub, to celebrate. During the revelries, a busboy lit a match while trying to change a light bulb and accidentally set a decorative palm tree on fire. Almost immediately, the whole nightclub, which was packed beyond its legal capacity, was engulfed in flames. Nearly 500 people lost their lives in that tragedy. Afterward, Lindemann and his colleagues worked with the family members who had lost loved ones in that tragedy, and from these data and others, he wrote his classic paper, The Symptomatology and Management of Acute Grief, in 1944. From his observations of 101 recently bereaved patients, he discovered similar patterns, which he described as the pathognomic characteristics of normal or acute grief. 1. Somatic or bodily distress of some type. 2. Preoccupation with the image of the deceased. 3. Guilt relating to the deceased or circumstances of the death. 4. Hostile reactions. 5. The inability to function as one had before the loss. In addition to these 5, he described a 6th characteristic exhibited by many patients. They appeared to develop traits of the deceased in their own behavior. There are many limitations to Lindemann's study. Some of these have been outlined by Parks in 2001, who points out that Lindemann does not present figures to show the relative frequency of the syndromes described. Lindemann also neglects to mention how many interviews he had with the patients and how much time had passed between the interviews and the date of the loss. Nevertheless, this remains an important and much-cited study. What is of particular interest to me is that the bereaved we see today at Massachusetts General Hospital exhibit behaviors very similar to those described by Lindemann more than 60 years ago. In a large number of people undergoing an acute grief reaction, we find some or most of the following phenomena. Because the list of normal grief behaviors is so extensive and varied, I have placed them under 4 general categories: feelings, physical sensations, cognitions, and behaviors. Anyone counseling the bereaved needs to be familiar with the broad range of behaviors that falls under the description of normal grief. Feelings. Sadness. Sadness is the most common feeling found in the bereaved and really needs little comment. This feeling is not necessarily manifested by crying behavior, but often it is. Parks and Weiss in 1983 conjecture that crying is a signal that evokes a sympathetic and protective reaction from others and establishes a social situation in which the normal laws of competitive behavior are suspended. Some mourners have a fear of sadness, especially the fear of its intensity. It is not uncommon to hear a person say, "I lost it at the funeral." Still, others try to block sadness through excessive activity, only to discover that the sadness comes out at night. Not allowing the sadness to be experienced with or without tears can frequently lead to complicated mourning. Anger. Anger is frequently experienced after a loss. It can be one of the most confusing feelings for the survivor, and as such is at the root of many problems in the grieving process. A woman whose husband died of cancer said to me, "How can I be angry? He didn't want to die." The truth is that she was angry at him for dying and leaving her. If the anger is not adequately acknowledged, it can lead to complicated mourning. This anger comes from two sources: from a sense of frustration that there was nothing one could do to prevent the death, and from a kind of regressive experience that occurs after the loss of someone close. You may have had this type of regressive experience when you were a very young child on a shopping trip with your mother. You were in a department store and suddenly you looked up to find that she had disappeared. You felt panic and anxiety until your mother returned, whereupon, rather than express a loving reaction, you hauled off and kicked her in the shins. This behavior, which Bowlby sees as part of our genetic heritage, symbolizes the message, "Don't leave me again." In the loss of any important person, there is a tendency to regress, to feel hopeless, to feel unable to exist without the person, and then to experience the anger that goes along with these feelings of anxiety. The anger that the bereaved person experiences needs to be identified and appropriately targeted toward the deceased in order to make a healthy adaptation. However, it often is handled in other less effective ways, one of which is displacement, or directing it towards some other person and often blaming him or her for the death. The line of reasoning is that if someone can be blamed, then that person is responsible, and hence the loss could have been prevented. People may blame the physician, the funeral director, family members, an insensitive friend, and frequently God. Quote, "I feel cheated, but I'm confused not knowing who cheated me. God showed me something so precious and takes it away. Is this fair?" End quote, queried one widow. One of the riskiest maladaptations of anger is the posture of turning the anger inward against the self. In a severe case of retroflected anger, the person may be down on him or herself and could develop severe depression or suicidal behavior. A more psychodynamic interpretation of this retroflected anger response was given by Melanie Klein in 1940, who suggests that the quote-unquote triumph over the dead causes the bereaved person to turn his or her anger against him or herself or direct it outward toward others nearby. Guilt and self-reproach. Guilt and self-reproach over not being kind enough, over not taking the person to the hospital sooner, and the like, are common experiences of survivors. Usually the guilt is manifested over something that happened or something that was neglected around the time of the death, something that may have prevented the loss. Most often the guilt is irrational and mitigates through quote-unquote reality testing. There is, of course, the possibility of real guilt, where the person has indeed done something to cause the death. In these cases, interventions other than reality testing would be called for. Anxiety. Anxiety in the survivor can range from a light sense of insecurity to a strong panic attack, and the more intense and persistent the anxiety, the more it suggests an abnormal grief reaction. Anxiety comes primarily from two sources. First, fear the survivor will not be able to take care of him or herself on their own, and frequently comment, "I won't be able to survive without him." Second, anxiety relates to a heightened sense of personal death awareness, the awareness of one's own mortality heightened by the death of a loved one. Carried to extremes, this anxiety can develop into a full-blown phobia. The well-known author C.S. Lewis in 1961 knew this anxiety and said after losing his wife, "No one ever told me that grief felt so like fear. I'm not afraid, but the sensation is like being afraid. The same fluttering in the stomach, the same restlessness, the yawning. I keep on swallowing." Loneliness. Loneliness is a feeling frequently expressed by survivors, particularly those who have lost a spouse and who were used to a close day-to-day relationship. Even though very lonely, many widows will not go out because they feel safer in their homes. "I feel so alone now," said one widow who had been married for 52 years. "It's been like the world has ended," she told me 10 months after her husband's death. Strobe, Abakumkin, and Shute in 1996 distinguished between emotional loneliness and social loneliness. Social support can help with social loneliness, but does not mitigate against emotional loneliness due to a broken attachment. The latter can only be remedied by the integration of another attachment. Sometimes the need to be touched is a correlate of loneliness. This is especially true in cases of conjugal bereavement. Fatigue. Lindemann's patients reported fatigue, and we see this frequently in survivors. It may sometimes be experienced as apathy or listlessness. This high level of fatigue can be both surprising and distressing to the person who is usually very active. "I can't get out of bed in the morning," said one widow. "I am neglecting the house because I am tired all the time." Fatigue is usually self-limiting. If not, it may be a clinical sign of depression. Helplessness. One factor that makes the event of death so stressful is the sense of helplessness it can engender. This close correlate of anxiety is frequently present in the early stage of a loss. Widows in particular often feel extremely helpless. A young widow left with a 7-week-old child said, "My family came and lived with me for the first 5 months. I was afraid I would freak out and not be able to care for my child." Shock. Shock occurs most often in the case of a sudden death. Someone picks up the telephone and learns that a loved one or a friend is dead. Even when the death is expected and follows a progressive deteriorating illness, when the phone call finally comes, it can still cause the survivor to experience shock. Yearning. Yearning for the lost person is what the British call pining. Parks in 2001 has noted that pining is a common experience of survivors, particularly among the widows he studied. Yearning is a normal response to loss. When it diminishes, it may be a sign that mourning is coming to an end. When it does not come to an end, it may be a clinical sign indicating traumatic grief. See Chapter 5 for discussion of traumatic grief as one of the complications of mourning and the place of yearning in its diagnosis. Emancipation. Emancipation can be a positive feeling after a death. I worked with a young woman whose father was a real potentate, a heavy-handed, unbending dictator over her existence. After his sudden death from a heart attack, she went through the normal grief feelings, but she also expressed a feeling of emancipation because she no longer had to live under his tyranny. At first she was uncomfortable with this feeling, but later she was able to accept it as the normal response to her changed status. Relief. Many people feel relief after the death of a loved one, particularly if the loved one suffered a lengthy or particularly painful illness. The knowing that his suffering, both physical and mental, is over helps me cope, said one elderly widow. It can also occur when the death involves a person with whom the mourner has had a particularly difficult relationship, often lifelong. Sometimes relief is the reaction following a completed suicide. However, a sense of guilt often accompanies this sense of relief. Numbness. It's also important to mention that some people report a lack of feeling. After a loss, they feel numb. Again, this numbness is often experienced early in the grieving process, usually right after the person learns of the death. It probably occurs because there are so many feelings to deal with that to allow them all into consciousness would be overwhelming, so the person experiences numbness as a protection from this flood of feelings. Commenting on numbness, Parks and Weiss have said, "We found no evidence that it is an unhealthy reaction. Blocking of sensation as a defense against what would otherwise be overwhelming pain would seem to be extremely normal." End quote. As you review this list, remember that each of these items represents normal grief feelings, and there is nothing pathological about any one of them. However, feelings that exist for abnormally long periods of time and at excessive intensity may portend a complicated grief reaction. Physical sensations. One of the interesting things about Lindemann's paper is that he describes not only the emotions that people experience, but also the physical sensations associated with their acute grief reactions. These sensations are often overlooked, but they play a significant role in the grieving process. The following is a list of the most commonly reported sensations experienced by the people we see for grief counseling. 1. Hollowness in the stomach. 2. Tightness in the chest. 3. Tightness in the throat. 4. Oversensitivity to noise. 5. A sense of depersonalization. Quote, I walk down the street and nothing seems real, including me, end quote. 6. Breathlessness or feeling short of breath. 7. Weakness in the muscles. 8. Lack of energy. 9. Dry mouth. Many times these physical sensations are of concern to the survivor, and he or she will come to the physician for a checkup. Physicians need to inquire about deaths and losses. Cognitions. There are many different thought patterns that mark the experience of grief. Certain thoughts are common in the early stages of grieving and usually disappear after a short time. But sometimes thoughts persist and trigger feelings that can lead to depression or anxiety. Disbelief. Quote, it didn't happen. There must be some mistake. I can't believe it happened. I don't want to believe it happened, end quote. These are often the first thoughts to occur after hearing of a death, especially if the death was sudden. One young widow said to me, I keep waiting for someone to wake me and tell me I'm dreaming. Another said, the passing of my husband came as a shock, although he had been sick for some time. You are never quite ready for it, end quote. Confusion. Many newly bereaved people say their thinking is very confused. They can't seem to order their thoughts. They have difficulty concentrating, or they forget things. I once went out for a social evening in Boston and took a cab home. I told the driver where I wanted to go and sat back while he proceeded down the road. A little later, he asked me again where I wanted to go. I thought maybe he was a new driver and did not know the city, but he commented to me that he had a lot on his mind. A little later, he asked again and then apologized and said he was feeling very confused. This happened several more times, and finally I decided it would not hurt to ask him what was on his mind. He told me that his son had been killed the week before in a traffic accident. Preoccupation. Preoccupations can be obsessive thoughts about the deceased. These often include obsessive thoughts about how to recover the lost person. Sometimes preoccupation takes the form of intrusive thoughts or images of the deceased suffering or dying. In our Harvard child bereavement study, surviving parents with the highest levels of intrusive thoughts were those who unexpectedly lost a spouse with whom they had a highly conflicted relationship. Rumination is another form of preoccupation. People engaging in ruminative coping think persistently and repetitively about how bad they feel and about the circumstances that precipitated their feelings. Sense of presence. This is the cognitive counterpart to the experience of yearning. The grieving person may think that the deceased is somehow still in the current area of time and space. This can be especially true during the time shortly after the death. In our study of bereaved children, 81% of the children felt watched by their dead parent 4 months after the death, and this experience continued for many of the children, 66%, 2 years after the death. Some found the sense of presence comforting, while others did not and were scared by it. Hallucinations. Hallucinations of both the visual type and the auditory type are included in this list of normal behaviors because hallucinations are a frequent experience of the bereaved. They are usually transient, illusory experiences, often occurring within a few weeks following the loss, and generally do not portend a more difficult or complicated mourning experience. Although disconcerting to some, many others find these experiences helpful. With all the recent interest in mysticism and spirituality, it is interesting to speculate whether these are really hallucinations or possibly some other kind of metaphysical phenomenon. There is an obvious interface between thinking and feeling, and the current interest in cognitive psychology and cognitive therapy emphasizes this. Aaron Beck and his colleagues in 1979 at the University of Pennsylvania found that the experience of depression frequently is triggered by depressive thought patterns. In the bereaved, certain thoughts will pass through the mind such as, "I can't live without her," or "I'll never find love again." These thoughts can then trigger very intense but normal feelings of sadness and or anxiety. Behaviors. There are a number of specific behaviors frequently associated with normal grief reactions. These can range from sleep and appetite disturbances to absent-mindedness and social withdrawal. The following behaviors are commonly reported after a loss and usually correct themselves over time. Sleep disturbances. It is not unusual for people who are in the early stages of loss to experience sleep disturbances. These may include difficulty going to sleep or early morning awakening. Sleep disturbances sometimes require medical intervention, but in normal grief, they usually correct themselves. In the Harvard Child Bereavement Study, 1/5 of the children showed some sleep disturbance in the first 4 months after the death of one of their parents. Without any special intervention, this figure dropped to a level not significantly different from that of their non-bereaved matched counterparts 1 and 2 years following the death. After Bill lost his wife suddenly, he would wake up at 5 o'clock each morning filled with intense sadness and review over and over the circumstances surrounding the death and how it might have been prevented, including what he might have done differently. This happened morning after morning and soon caused problems because he could not function well at work. After about 6 weeks, the disorder began to correct itself and eventually it disappeared. This is not an unusual experience. However, if sleep disorder persists, it may indicate a more serious depressive disorder, which should be explored. Sleep disorders can sometimes symbolize various fears, including the fear of dreaming, the fear of being in bed alone, and the fear of not awakening. After her husband died, one woman solved the problem posed by her fear of being alone in bed by taking her dog to bed with her. The sound of the dog's breathing comforted her, and she continued to do this for almost a year until she was able to sleep alone. Appetite disturbances. Bereaved animals exhibit appetite disturbances, which are also very common in human mourning situations. Although appetite disturbances can manifest themselves in terms of both overeating and undereating, undereating is the more frequently described grief behavior. Significant changes in weight may result from changes in eating patterns. Absent-minded behavior. The newly bereaved may find themselves acting in an absent-minded way or doing things that may ultimately cause some inconvenience or harm. One client was concerned because on 3 separate occasions she had driven across the city in her car and after completing her business had forgotten that she had driven and returned home via public transportation. This behavior occurred following an important loss and eventually corrected itself. Social withdrawal. It is not unusual for people who have sustained a loss to want to withdraw from other people. Again, this is usually a short-lived phenomenon and corrects itself. I saw one young woman shortly after the death of her mother. This single woman was a very sociable person who loved to go to parties. For several months following her mother's death, she declined all invitations because they seemed dissonant to the way she felt in the early stages of her grief. This may seem obvious and appropriate to the reader, but this woman saw her withdrawal as abnormal. Some people withdraw from friends perceived as oversolicitous. Quote, "My friends tried so hard that I wanted to avoid them. How many times can you hear, 'I'm sorry'?" End quote. Social withdrawal can also include a loss of interest in the outside world, such as not reading newspapers or watching television. Dreams of the deceased. It's very common to dream of the dead person, both normal kinds of dreams and distressing dreams or nightmares. Often these dreams serve a number of purposes and may give some diagnostic clues as to where the person is in the whole course of mourning. For example, for several years after the death of her mother, Esther suffered from intense guilt over circumstances related to the death. This guilt was manifested in low self-esteem and personal recrimination and was associated with considerable anxiety. During one of her daily visits to her mother, Esther had left for coffee and a bite of food. While she was out, her mother died. Esther was filled with remorse, and although we used the usual reality testing techniques in therapy, the guilt still persisted. While in therapy, she had a dream about her mother. In this dream, she saw herself trying to assist her mother to walk down a slippery pathway so she would not fall. But her mother fell, and nothing Esther could do in the dream would save her. It was impossible. This dream was a significant turning point in her therapy because she allowed herself to see that nothing she could have done would have kept her mother from dying. This important insight gave her permission to shed the guilt she had been carrying for years. Avoiding reminders of the deceased. Some people will avoid places or things that trigger painful feelings of grief. They might avoid the place where the deceased died, the cemetery, or objects that remind them of their lost loved one. One middle-aged woman came for grief counseling when her husband died after a series of coronary attacks, leaving her with 2 children. For a period of time, she put all pictures of her husband away in the closet, along with other things that reminded her of him. This obviously was only a short-term solution, and as she moved toward the end of her grief, she was able to bring out the items that she wanted to live with. Quickly getting rid of all the things associated with the deceased, giving them away or disposing of them in any way possible, even to the point of having a quick disposal of the body, can lead to a complicated grief reaction. This is usually not healthy behavior and is often indicative of a highly ambivalent relationship with the deceased. Searching and calling out. Both Bowlby and Parks have written much in their work about searching behavior. Calling out is related to the searching behavior. Frequently, somebody may call out the name of the loved person. John, 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 please come back to me. When this is not done verbally, it can be going on internally. Sighing. Sighing is a behavior frequently noted among the bereaved. It is a close correlate of the physical sensation of breathlessness. Colleagues at Massachusetts General Hospital tested respiration in a small group of bereaved parents and found that their oxygen and carbon dioxide levels were similar to those found in depressed patients. Restless hyperactivity. A number of widows in our Harvard studies of bereavement entered into restless hyperactivity following the deaths of their husbands. The woman mentioned above, whose husband left her with 2 teenage children, could not stand to stay at home. She would get into her car and drive all over town, trying to find some sense of relief from her restlessness. Another widow could stay in the house during the day because she was busy, but at night she fled. Crying. There's been interesting speculation that tears may have potential healing value. Stress causes chemical imbalances in the body, and some researchers believe that tears remove toxic substances and help reestablish homeostasis. They hypothesize that the chemical content of tears caused by emotional stress is different from that of tears secreted as a function of eye irritation. Tests are being done to see what type of catecholamine, in parentheses, mood-altering chemicals produced by the brain, close parentheses, is present in tears of emotion. Tears do relieve emotional stress, but how they do this is still a question. Further research is needed on the deleterious effects, if any, of suppressed crying. Visiting places or carrying objects that remind the survivor of the deceased. This is the opposite of the behavior that people engage in to avoid reminders of the lost person. Often underlying this behavior is the fear of losing memories of the deceased. For 2 weeks, I carried his picture with me constantly for fear I'd forget his face, one widow told me. Treasuring objects that belonged to the deceased. One young woman went through her mother's closet shortly after her mother died and took many of her clothes home. They were the same size, and although this might seem like an example of someone being thrifty, the fact was that the daughter did not feel comfortable unless she was wearing something that had belonged to her mother. She wore these clothes for several months. As her mourning progressed, she found it less and less necessary to wear clothing that had belonged to her mother. Finally, she gave most of it away to charity. The reason for outlining these characteristics of normal grief in such detail is to show the wide variety of behaviors and experiences associated with loss. Obviously, not all of these behaviors will be experienced by one person. However, it is important for bereavement counselors to understand the wide range of behaviors covered under normal grief so they do not pathologize behavior that should be recognized as normal. Having this understanding will also enable counselors to give reassurance to people who experience such behavior as disturbing, especially in the case of a first significant loss. However, if these experiences persist late in the bereavement process, they may be indicative of a more complicated grief. Grief and depression. Many of the normal grief behaviors may seem like manifestations of depression. To shed some light on this, let's look at the debate about the similarities and differences between grief and depression. Freud, in his early paper Mourning and Melancholia, addressed this issue. He tried to point out that depression, or melancholia, as he called it, is a pathological form of grief and is very much like mourning, parentheses, normal grief, close parentheses, except that it has a certain characteristic feature of its own, namely, angry impulses toward the ambivalently loved person turned inward. It is true that grief looks very much like depression, and it is also true that grieving may develop into a full-blown depression. Gerald Klarman, who was a prominent depression researcher, believed that many depressions are precipitated by losses either immediately following the loss or at some later time when the patient is reminded of the loss. Depression may also serve as a defense against mourning. If anger is directed against the self, it is deflected away from the deceased, and this keeps the survivor from dealing with the ambivalent feelings toward the deceased. The main distinctions between grief and depression are these. While in depression as well as grief, you may find the classic symptoms of sleep disturbance, appetite disturbance, and intense sadness. However, in a grief reaction, there is not the loss of self-esteem commonly found in most clinical depressions. That is, the people who have lost someone do not have less regard for themselves as a result of such a loss, or if they do, it tends to be only for a brief time. And if the survivors of the deceased experience guilt, it is usually guilt associated with some specific aspect of the loss rather than a general overall sense of culpability. A section of the Diagnostic and Statistical Manual -TR of the American Psychiatric Association suggests, quote, as part of their reaction to the loss, some grieving individuals present with symptoms characteristic of a major depressive episode, parentheses, e.g. feelings of sadness and associated symptoms such as insomnia, poor appetite, and weight loss, close parentheses. The bereaved individual typically regards the depressed mood as normal, although the person may seek professional help for relief of associated symptoms such as insomnia or anorexia, end quote. Even though grief and depression share similar objective and subjective features, they do seem to be different conditions. Depression overlaps with bereavement, but is not the same. Freud believed that in grief, the world looks poor and empty, while in depression, the person feels poor and empty. These differences in cognitive style have been identified by Beck and Associates and other cognitive therapists who have suggested that the depressed have negative evaluations of themselves, the world, and the future. Although such negative evaluations can exist in the bereaved, they tend to be more transient. However, there are some bereaved individuals who do develop major depressive episodes following a loss. The APA Diagnostic and Statistical Manual, 4th edition, allows for this distinction. Symptoms associated with depression rather than grief are guilt about things other than actions taken or not taken by the survivors at the time of the death, the survivor's thoughts of death other than the feeling that he or she would be better off dead or should have died with the deceased person, morbid preoccupation with worthlessness, marked psychomotor retardation, prolonged and marked functional impairment, and hallucinatory experiences, parentheses, this does not include experiences of hearing the voice of or transiently seeing the image of the deceased person, close parentheses. If a major depressive episode develops during bereavement, this should be considered a type of complicated mourning, exaggerated grief. At Yale, Jacobs and colleagues have been interested in depression within the context of bereavement and have said, quote, although the majority of depressions of bereavement are transient and require no professional attention, there is growing appreciation that some depressions, especially those that persist throughout the first year of bereavement, are clinically significant, end quote. They have used antidepressant medication to treat several patients whose depression persisted late in the course of bereavement and did not resolve spontaneously or respond to interpersonal interventions. These were usually people who had a history of depression or some other mental health disorder. They found improvement in sleep disorders and appetite disturbance, as well as an improvement in mood and cognition. This response suggests a biological dimension to the depression. One of the functions of the counselor who has contact with people during the time of acute grief is to assess which patients might be undergoing a major depression by using current standard diagnostic criteria. Patients so identified can then be given additional help, such as a medical evaluation, possibly the use of antidepressant medications. Once depressions begin to lift through medication, then the focus of treatment changes to the underlying conflicts of the attachment. These conflicts cannot be addressed through medications alone. If grief is defined as one's experience after a loss, then mourning is the process one goes through leading to an adaptation to the loss. In the next 2 chapters, we'll look at the mourning process in detail.